Hi everyone, I'm Andrew Guyman. I'm a fourth year medical student at the University of South Dakota, Sanford School of Medicine. We're continuing our lecture series on Anesthesiology 101. Today, we're on day 9. We're discussing neuromuscular blockade and reversal. A couple of the learning objectives that we'll cover. So we'll begin by discussing advantages and disadvantages to paralyzing a patient. Then we'll discuss the depolarizing agent. There's really just one that's used in humans, that's succinylcholine. We'll move on to discussing non-depolarizing agents. There's multiple different ones. The most commonly used is rocuronium. Then we'll discuss paralysis monitoring, how we do that clinically using the train of 4, and specifically if you begin to see diaphragm motion, what could be causing that, and then extubation criteria. So paralyzing a patient allows endotracheal tube intubation. It's almost always used when you're trying to place an endotracheal tube. It prevents the glottis, the vocal cords, from spasming and closing on the endotracheal tube as you try to place it. It allows or enables mechanical ventilation by paralyzing the diaphragm. So your body isn't trying to breathe on top of the machine that's ventilating the body. And then it optimizes surgical conditions by forcing the patient to be paralyzed to hold still so that the surgeon can operate better. One of the major disadvantages of paralyzing a patient is prolonged paralysis. So if a patient's respiratory muscles are paralyzed, then you have to keep them intubated and continue to treat them and manage them, which can extend the time of surgery. Another major disadvantage is going to be that you have to manage the airway. So as soon as you paralyze a patient, they're unable to breathe on their own, and you must be able to place some sort of breathing device or mask ventilate them to make sure that they continue to breathe. So that's a major risk. And then specifically with succinylcholine, that can cause malignant hypertension, and then in certain scenarios, we'll discuss those, but you also have increased risk or a serious risk of hyperkalemia. The first paralytic that we'll discuss is succinylcholine. So succinylcholine mimics the action of acetylcholine. You can remember this because both of these have the choline suffix. Because it mimics that, it's a depolarizing agent because acetylcholine is your body's physiologic depolarizing agent that causes muscle contraction. It overstimulates the neuromuscular junction and then causes desensitization to acetylcholine following its use. When the neuromuscular junction is desensitized to acetylcholine, then the body would be paralyzed in that area. You treat or you use 1 milligram of succinylcholine per kilogram IV. And then occasionally, you might see some providers give a sub-paralyzing dose 2 to 4 minutes beforehand to prevent fasciculations. So because succinylcholine is a depolarizing agent, when you give it, patients can have like fasciculations or kind of twitch or spasm. That can cause myalgias in the post-op period when they wake up where their muscles ache. If you give a little bit of succinylcholine before you give the full dose, then that can prevent fasciculations and then maybe prevent the myalgias on the back end. Kind of the claim to fame or the most important effects of succinylcholine is going to be the rapid onset and short duration. So onset occurs between 30 and 60 seconds after giving it. So this is going to be the medication that is used very commonly for rapid sequence induction. And then it has a short duration, so it'll only last 5 to 10 minutes. Non-depolarizing agents are another class of paralytics. The most common one that you'll see is rocuronium. Rocuronium was named because of rapid onset curonium. Curonium is the paralyzing molecule. There's other non-depolarizing neuromuscular blockers that also are based off of the curonium molecule, but rocuronium is the one that you'll see used most commonly. It's non-depolarizing, so succinylcholine depolarizes at the neuromuscular junction, and then it causes desensitization to acetylcholine. Rocuronium antagonizes the acetylcholine receptor and then prevents acetylcholine from being able to act on the receptor. The most common dose that you'll see is 0.6 milligrams per kilogram, and that has an onset of action of about 1 to 2 minutes. So you can see that that's about double the time that succinylcholine acts. It lasts longer, so has a duration of about 20 to 35 minutes. Rocuronium can be reversed with sugammadex. So once you get to the end of a surgery, if your patient is still paralyzed, maybe you do train of 4 monitoring, and if they're still paralyzed, then you could give sugammadex to reverse that. And then rocuronium is excreted mostly via the bile, but about 30% can be excreted renally. So if a patient has chronic kidney disease where they're not producing any urine, then they could have prolonged paralysis. Dr. Iverson at Sanford, his take on the renal excretion of rocuronium is if a patient is fully dependent on dialysis, then he's not too concerned about it because they could always be dialyzed if they were still paralyzed, or if they had extended effects from the rocuronium. If a patient doesn't have chronic kidney disease, then of course you don't have to worry about it. But there's some patients who are kind of in a middle zone where they're moving into dialysis, but they don't have a fistula set up yet, and then they're producing very small amounts of urine. And then in those patients where you don't have an option to dialyze them, but they're producing minimal urine, then he would switch to using a different paralytic agent that was not eliminated as much renally. So if you're trying to monitor the degree of paralysis that a patient has, clinically, you could do it through like a sustained head lift or sustained leg lift. To be honest, I've never seen this done in practice. Maybe if you don't have the option of train of 4, then those would be techniques that you could rely on. Train of 4 is a monitor that evaluates the degree of paralysis that a patient has after receiving a neuromuscular blocker. So it's called Train of 4 because it delivers 4 electrical shocks spaced a half a second apart. And then either qualitatively, you can feel to see how many of those shocks elicit like a muscle spasm in response to it, or there's quantitative monitors which measure the shocks and then can return like a number, a numerical value that gives you information on how paralyzed the patient is. So in a qualitative sense, there's 4 shocks that are delivered, so then you could grade it between 0 out of 4 and 4 out of 4. So if you deliver 4 shocks and then you only feel their hand or their eye twitch once in response, then that would be like 1 out of 4. Where if you deliver 4 shocks and then you feel a twitch in response to each of those shocks, that would be graded 4 out of 4. If you have one of the quantitative measures or one of the quantitative monitors, then that can report a value between 0 to 1.0. And that's going to be grading the number of total shocks in response, or the number of total like spasms or twitches in response to each shock, along with an idea called fade. So what fade means is it delivers 4 shocks, and then if the first one, if you get like a pretty significant response to it, and then the second one you get a smaller response, and then the third one you get very small, and then the next one you don't get any. So the strength of each spasm in response to the shock is fading. And then it'll use that to return a numerical value between 0 and 1. And if you have a train of 4 value from a quantitative monitor that's greater than 0.9, greater or equal to 0.9, then that's sufficient evidence that the patient would be safe from a neuromuscular blockade perspective to be extubated. And then finally, one question that you could get pimped on or that's posed is, say you have a patient who's paralyzed, you try to evaluate them using train of 4 on their ulnar nerve, so on their arm to see if there's any response, and you get 0 out of 4 twitches, so it seems like they should be adequately paralyzed, but there's diaphragm motion. Most likely what this sort of question is getting at is the diaphragm is going to be the most resistant or refractory to neuromuscular blockade. So it's the muscle that takes the longest when you paralyze a patient to become paralyzed, and then it's going to be the first muscle to return. So even if you have 0 out of 4 twitches in the peripheral muscular system, you could still have diaphragm motion because your diaphragm is going to be more resistant than your ulnar nerve or your upper extremity muscles to paralysis. So the last topic that we'll discuss is how to know if a patient is ready to be extubated. So The Stanford CA1 manual gives 7 different criteria normally that you would look at if you're going to extubate a patient. Open anesthesia, they add one more criteria, the risk assessment beforehand. So when you come to the end of a surgery, you're considering extubating the patient, the first thing to look at or to think about is assessing if this patient was a difficult intubation or if they were difficult to mask ventilate, or if you have the equipment in the room, if you were suspicious that these could be problems, but if you'd be ready to reintubate or mask ventilate if needed. Then assessing vital signs to see if those are stable. An arterial blood gas should be reasonable if you had a large surgery and this was something that you were monitoring. And then reversing the neuromuscular blockade is going to be essential because the patient will need their respiratory muscles in function to be able to self-ventilate. So if a non-depolarizing agent was used, like rocuronium, then you could use sugammadex. The other way that you could evaluate this is if you have a train of 4 monitor that can produce quantitative values, then this should be greater than 0.9, greater than or equal to. And then that's criteria enough that it would be safe for them to be extubated from a neuromuscular perspective. The patient's respiratory mechanics should be adequate. So while they're intubated at this stage, you could just be providing pressure support, ventilation. So you're not really breathing for them. You're just helping them overcome the resistance of the anesthesia machine and the endotracheal tube that they have to breathe through. Their spontaneous ventilation breaths should be greater than 5 milliliters per kilogram. So making sure that they have adequate tidal volume, and then ensuring that the patient is out of stage 2 of anesthesia. They would be more likely to bronchospasm or laryngospasm if you extubated them in stage 2. You could evaluate this based on their vital signs. If those are elevated, that could be a sign that they're in stage 2, or if they have a deconjugate gaze where their eyes are kind of like crazy eyes and focused in different directions, and that could be like a indication that they're in stage 2, and you would not want to extubate then. And then making sure that they have their protective reflexes returned. So that would be like their gag reflex, swallow reflex, coughing reflex. So if they're gagging or bucking while you're waiting to extubate, those would be indications that those reflexes have come back. If a patient can follow commands, then they should be able to protect their airway, and then optimizing the patient. So placing them on 100% oxygen before extubating to try to increase the reserve in case something were to go haywire, and then placing them in a slight reverse Trendelenburg position, so where they're sitting upright a little bit, making sure that you have suction readily available, and then you can also suction their airway immediately beforehand to prevent them from aspirating or choking on any of their saliva. And then if they are still coughing, we discussed how lidocaine can be used to produce areflexia. So you could give them lidocaine to try to reduce the coughing that is caused at just prior to extubation. I hope that this helps. Let me know if you have any questions. I'd be happy to try to find some answers. And I'm sure all of our attendings are far more knowledgeable than me. I hope this helps.